Okay, we're going to transition to our old friend, the band. So this is a 45-year-old female who's had a history of a laparoscopic adjustable band, presented acutely to the emergency department, which is a little bit unusual with these band complications. She'd had about a week-long history of abdominal pain and then had a couple days of malaise and actual documented fevers and nausea, vomiting. Pertinent to the history, she had not had an adjustment in years, and her band had been placed. I did this case in 2016, so it had been in for 4 years. And interestingly, looking at the old operative report, there had been an intraoperative gastric perforation of note. So in the emergency room, she's febrile and tachycardic and probably relative hypotension for this individual and appeared ill, guarding in her left upper quadrant and quite tender with visible edema and redness over her port and leukocytosis. This is her imaging. So we can see what appears to be an almost completely intraluminal gastric band. And shown on the right-hand side, I was just getting an image where you can see actually the induration along the track of the intra-abdominal tubing. Okay, so we're kind of same options here. So we'll start with Dr. Crawford in terms of non-op management with antibiotics, endoscopic only, combined, or all MIS?
I think I would probably go with the combined endoscopic and MIS. I have never removed any band like this completely endoscopically. I know it's been described, but I've only removed like a little piece of mesh, like VBGB type. And I would want to remove the entire aspect of the band. I've seen people have to go back later and remove the second infected component, so I prefer to do it all in one. But with that much of the band in the stomach, you may be able to cut the tubing and then release the rest of it into there.
Yeah, I would scope the patient and see what the situation looks like, and if I have a good portion of it migrated into the stomach, I would go endoscopically and then watch the patient, of course, and see how it goes. You could always check if you remove it completely when you remove it and see if there are some parts missing. Mm-hmm. Just don't throw it away before you made sure that everything is out. Mm-hmm.
I agree. I would endoscopically likely remove the band if it's eroded sufficiently, and then I would remove the port subcutaneously. I'm not sure I need to have a laparoscope in the belly at all at this point.
Yeah, I agree. I think this is obviously the band eroded intraluminally. The tract got infected, so you need to just release the tract, remove the whole thing endoscopically, and manage that tract infection. If you start dissecting up in this area, you're going to end up with a big hole in the stomach that you're going to have to create a bigger problem, probably.
So lessons as a first-year attending in the middle of the night, kind of alluding to Dr. Camacho's case. My plan was to go and do an endoscopic removal, and then I found out I couldn't get any of the equipment I wanted. So here I am doing the endoscopy, and we just can't get anything down to the OR to go in the endo suite to pull this thing out. So I quickly had to pivot and come up with a different plan. So... Oh, the video didn't show. Let me see if I can go back here. Are you able to get that to play for me? There should be an arrow on it. I'm not getting them. There we go. Thank you. So it's completely intraluminal. You can see there's tubing there. The entire band is intraluminal. So ideally, I would have liked to take this out endoscopically. And then here's the pivoting. So put the laparoscope in and take a look. You can see, as expected from the amount of inflammation around the tubing, there were dense adhesions here. The colon was stuck up, the transverse colon mesentery, and so needed to try to get that down. And one of the things about, I guess, being a bariatric surgeon is we are pretty good at putting holes in things and then closing them back up. And so that's what I opted to do, was to do a gastrotomy in a kind of healthier appearing, not as indurated portion of the stomach, making a gastrotomy here with an energy device, and then initially thought, oh, I can do this through a kind of small gastrotomy, but the band always appears a lot bigger than what you think it's going to be. And so I had to make it probably about 2, ultimately 3 centimeters to really get a hold of the tubing there. You can see how this looks with the complete erosion. Cut the tubing and then stapled this off. So you can see there, that's about a 3 centimeter size gastrotomy there, but we're pretty comfortable making those holes and closing them back up. So that will leave us with the staple line here on the greater curvature. And then since I was there, went ahead and the tubing pulled out of the portion where the original band tract had been very easily. And so much like I would do for a potential ulcer perforation, placed some stitches here along this to close that down. And then the series following that is an omentoplasty that was done on top. And then towards the end of the video, to save time, just completing endoscopy showing a negative leak test. I did go ahead and move the reservoir as well, since we were there in the operating room. This is the upper GI obtained postoperative day number 1, which was normal, and patient had an uneventful recovery.